Hi, everyone. Thank you for joining us today for our sepsis work group. Very excited. We have a large group here today, and we are very excited to get things kicked off. So I will go ahead and um, move into our housekeeping items. So as you all just heard, this meeting is being recorded. It will be available later on our YouTube page to view and share with your coworkers. We will be having questions monitored in the chat, and we'll also have some time at the end for questions and discussion. And then we will be posting the work group survey at the end. For those of you that are from a P4P site and are looking to get credit towards P4P with your attendance today, it is mandatory that that survey is completed. And as a reminder, you also need to join for at least 80% of the meeting for it to count for your credit. So with us today, we have Irene Johnston. She is RN that has her MSN and brings a wealth of expertise to the forefront of healthcare as the executive director of quality patient safety, infection prevention, and risk at Oaklawn Hospital in Marshall, Michigan. She began her healthcare career in long-term care as a nurse aide. She has achieved both her practical nurse and associate's degree in nursing at Kellogg Community College in 1999 and 2000. In 2010, Irene completed the Bachelor of Science program at Robert B. Miller College, and in 2021 was awarded a Master of Science with an emphasis in healthcare leadership from Grand Canyon University. Irene has held a variety of roles in the healthcare industry over the past 30 years. She has served at Oaklawn Hospital since February of 2003 in the medical surgical unit as a primary care RN, clinical nurse educator coordinator, and the clinical nurse director. And she has been the director in the quality department for the last 3 years. Her professional goals align with the organization's mission and vision, which is to strive for perfect care every time for all those served. Thank you, Irene, for your long service in the healthcare industry and for presenting for us today.
Thank you very much. Thank you for the introduction and allowing me this opportunity to speak with you all today. It is my hope that you'll be able to take something away from what I share with how Oaklawn has worked through sepsis. And we've got a long way to go, but some of our achievements, and I hope you can take something away. Next slide. First, before we get too far into things, I do need to mention that I do not have any financial conflicts of interest to disclose. And I do want to share a little bit about Oaklawn. Next slide. So Oaklawn was founded in 1925 as a 12-bed hospital and a residential home, funded by a group of visionary philanthropists. Now, almost a century later, we've evolved into a highly regarded regional healthcare organization. We are licensed for 77 acute care beds, and we have a 17-bed inpatient psychiatric unit. We've continued to be an independently owned, not-for-profit hospital, and our main campus still resides on the same site as the original house hospital, providing facilities, equipment, and technology that are usually only found at the larger health systems. We enjoy a reputation for advancing medicine and providing that compassionate and personal care. Next slide. Oaklawn is located in Southwest Michigan, kind of the middle. If you know where Route 69 and 94 intersect, that is where we're at on the green map on your screen there, that county and shaded in the black. And then the larger picture kind of shows our service area. The burgundy is our primary service area, and the gray is our secondary service areas. We serve Calhoun County, parts of Branch and Eaton. Our medical staff consists of more than 300 providers and represent over 55 specialties. Next slide. So why we're here, Sepsis Workgroup. This is a multidisciplinary subcommittee of the Infection Prevention and Control Committee. Our team consists of nursing and provider representation from our emergency department, both our med-surg and CCU inpatient units, pharmacy, infection prevention, lab including microbiology, and quality. Our meetings are being held about every other month. One of our committee goals was to decrease the 30-day readmissions related to sepsis, and that's what I'll tell you a little bit more about here. Go to the next slide. Overall, our 30-day all-cause readmissions CMS data is currently around 14.2%. To help prevent readmissions in general, our case management team works tirelessly to monitor patients' needs throughout their stay to ensure they have the appropriate resources at discharge. For those patients identified as high-risk readmission, the team works closely with the primary care providers and the care management team in those offices to help improve continuity of care and ensure there is follow-through once the patient is discharged. Next slide. Our readmission rate specifically pertaining to sepsis is displayed in this slide. I am using 2022 claims data, not risk-adjusted sepsis data, to help provide context for volume. Most of our patients with sepsis have severe sepsis without septic shock, and those with severe sepsis with shock have the highest readmission rate and mortality rate as displayed here. Next slide. This slide provides a look at the 30-day readmission demographic data based off of our 2022 claims information. Our 30-day readmission rate for those who had a diagnosis code for sepsis was 13.3%, while the state of Michigan had a 20.8 readmission rate. So we're proud of that. There is not significant variability with gender nor race and ethnicity. However, those 75 years of age or older do have a higher readmission rate. Next slide. So looking across time, now we're focusing on January 2020 through March of 23. Our 30-day readmission rate for those hospitalized with sepsis was in alignment with the data shown previously for just 2022. It's interesting, I just want to point out, I don't have the comparison data to explain it, but you'll note on 2021 quarter 1 and quarter 2, as well as in 22 quarter 2, there's some surges there, and those actually correlate with the inpatient COVID patients we were seeing during those timeframes. Next slide. And this is just a snippet of the readmissions among patients who are hospitalized and the reasons for readmission to Oaklawn or to a different facility. All right, next slide. This is kind of a homegrown view of some of the data. Our sepsis subcommittee reviews, we've been focusing on all of the abstracted charts that are randomly selected and then reported out. And our sepsis committee would review all of those fallout cases and discuss trends and develop action plans. So what you're seeing here is in calendar year 2022, which is the column to the far left, we identified trends in our sepsis abstraction fallouts. The highest fallout related to the timing of antibiotics and blood culture. Primarily, what we found was that it was remembering to complete the blood cultures first and then start the antibiotics. The second highest fallout reason was related to initial and the repeat lactate levels. Went through education and we were still finding these were falling out. So on review, we said, let's get a little bit deeper into the process. So the process is involved with both of these reasons were reviewed. We found that there was actually a documentation issue related to when the antibiotics were initiated to compare to when the blood cultures were drawn. Our ED clinical coordinator audited the process and observed the majority of the time the RN scanned the med, hung the antibiotic, and waited for the lab tech to complete that draw before starting the infusion. However, the timestamps that were in the EMR made it appear as though the antibiotics were started before the blood culture was drawn. So by going to the Gemba and seeing where the work was being done, watching what was actually occurring, it allowed for the ED team to adjust how they prepared for that timely intervention so that they're still ready to start that antibiotic as soon as the blood cultures were drawn, but it then also those were also reflected in the charting and the EMR. So for correcting the lactate timing and orders, that required education, but we also found a way to update our EMR to allow for automatic orders to be sent based off of the initial order and have that timing just reflex so that it was automatically happening. So you can see then if you look across the first quarter of 23, we recognize some improvement in with our changes that we made and corrective actions in both of those areas. And it continued into the second half of 2023. But as with all things, as compliance with the antibiotic and blood culture timing with lactates also was improving, we began to realize different measure fallouts. In 2023, the additional measure fallouts included target fluid volume, assessment for persistent hypotension, using vasopressin, as well as providers documenting their fluid status and tissue reperfusion assessments. So we created, again, went back to the team doing the work, and we did develop a couple of resources for reference tools, and those are what I would like to share with you today. Next slide. So this is our severe sepsis septic shock algorithm, just trying to find a creative way to help staff in the moment follow what is the right next step. And it was created by our ED coordinator and educator with assistance from our quality coordinator. We did get these approved, laminated, and then posted within our ER and the inpatient units. We rolled this form out in about mid-September. And as with all things, there's continuous improvement. The group was recently reviewing this, and we're looking at some ideas to try to maybe revamp it a little. There's a lot on here, and we want to have ways to make it a little bit more clear. But this was a good first start, and it really did help bring in some of those actions that needed to be taken. This should be an attachment with your meeting packet too. So if you would like to use this, we have no problem sharing that. Just if you can make it better and clearer, share it with us too. Next slide. So later in the late fall of 23, we were looking at the provider documentation and how could we best assist our docs. So our ED coordinator again went to work, and with the assistance of one of our ED providers, using the standards, developed this documentation tool for providers just as a reminder of what needs to be included so that they're getting credit for the work they're doing, and making sure that the care is being provided. This went out in November of 23 officially. So into January through March now, we're still working on those abstractions, and I don't have any data to really be able to say, yes, these two tools have made significant changes yet or improvement, but I think it is. My gut says it's helping, but these were some of the interventions we had. Next slide. What's new and initiatives for 2024? So to help us ensure the best sepsis care is provided to everyone who's in need, the quality team proposed to our sepsis subcommittee that we look at all the possible cases of sepsis, not just those that are randomly selected for the closed chart review and the required audit process for publicly reporting and value-based purchasing. So currently we have a third party that performs our sepsis chart abstractions and submission process. They do an excellent job, but there's that time delay. So we're 2 to 3 months before we really get to see the results and have that ability to identify where we can make improvements and then put those actions in place. So it's just that lag. So we want to try to get the whole picture for the process improvements, because the other pieces with the abstractions, there's no requirement to move forward in that chart that fell out. And so as soon as there's the fallout, they just stop abstracting. But we want to also be able to see the backside. It's like, okay, so maybe we missed something up front, but how did we do with the rest of the chart so that we can also then keep, if there's something, a process that we could try to improve there, we can do that. So that's where trying to look at these more in depth on our own is coming into play. So new for 2024, our quality coordinator started developing her own process to follow those with sepsis through hospitalization with the goal of validating the random sampling data and reasons for follow-up, but more importantly, to help identify those areas for opportunity in real time and perhaps improve care for the patient while they're still hospitalized, or at least help improve care more timely for the next patient. This process will allow us to identify what we do well, but also celebrate those accomplishments with the team. So with the audit process, we began this in mid-January and we're continuing to develop the whole standard of work. The first step was just getting a report to identify the patients. Our EMR is Cerner, and currently it is set up to send alerts to the bedside staff for SIRS and sepsis. Our analytics team helped to build and run a report every morning that identifies the patients with SIRS or sepsis in the past 24 hours. Jen will then use that information to review the reports and assess the patients that need to be monitored for sepsis in an Excel spreadsheet. If they're identified as meeting SIRS plus an infection or severe sepsis, they are worked up on a sepsis abstraction tool that she has, and that lists the different areas to monitor for the measure and references the spec manual. The cases are abstracted for all areas of the core measures, not just to identify potential opportunities for improvement. The case is followed through to final coding from medical records to see if it will qualify for the sepsis measure. The next step is to review these results with the results from our third-party abstractors. So that way we're learning too while we're using our experts with abstracting. So while we're developing the process to discuss, we're also developing a process to discuss best approach to communicate with physicians on the review findings and to work with our quality coordinator on education of the fallouts or near misses, and as well as education for the nurses and nursing staff. Another area that we are in the process of implementing is working with the finance director and clinical documentation and denial specialists on the disconnect between requirements for sepsis core measure and the documentation requirements for insurance companies and the denials for sepsis. We know this is a tough subject. It's I think a lot of facilities are probably struggling with this. I don't think we're alone, but we are trying to come up with a process that just helps the organization, but also making sure we're keeping the patient care front and center and doing what's best for our patients. Our sepsis subcommittee will continue to meet quarterly and review abstracted fallout cases, the real-time audit results, and the 30-day readmission data related to sepsis. In addition to, in addition to the team being made aware of the individual fallout areas, we have started to include the verbiage about fallout rationale from the sepsis manual, and it's version 5.15 to help reinforce the why and discuss how to improve. One last growth opportunity for our sepsis subcommittee is to partner with our antimicrobial stewardship committee. I am working closely with our clinical pharmacy specialist to bring these two meetings together, as most of the same individuals sit on both committees. So by combining these two meetings, not only will be making good use of our time and resources, we feel that it will be able to make the group, take both groups to the next level and achieve more. And I'm excited this idea is coming to fruition with our first combined meeting set for May 1st. And with that, next slide.
I have a question. I'm sorry. We're not seeing any slides. Do you have different slides?
No, just this one to say thank you.
Okay, thank you. I just wanted to make sure we're not missing any.
Yep, nope, I had the initiatives and just left it at that and talking points.
Great, thank you.
So thank you. And is there any questions? Other than I could have done better with my slides, I guess.
I think you did great. Thank you, Irene.
Thanks.
There are a couple questions in the chat, so we can kind of
Perfect.
start with those. The first question is from Amy. Besides 5 of 8 parameters, were there other options to meet exam?
And there are. Per the spec manual. We kept we didn't want to include everything, and we were using what is most feasible for our providers and what Oaklawn would be using to document for the tissue perfusion and hydration.
Thank you. Amy, did you, if you had any follow-up, please feel free to unmute yourself now, or you can also put it in the chat. It looks like Megan, you unmuted. Did you have a question? I don't know if you're talking, we can't hear you right now, but let's see. So we'll give folks a minute to either type into the chat if they have questions or raise their hand or just unmute themselves. I do have one thing that I wanted to kind of go back to. You showed some data that looked very familiar. It looked like you had gotten some data from MVC. Either was that a push report or custom analytics that was done? I know you guys have had a bit of both that you've utilized. I'm referring to, I can go back.
I believe that was push report.
Yes, that's what I thought. I just
Yep.
wanted to double check because
We've worked a lot on custom reports on our with ED. And so ED are some of our readmission rates or provider. They've been seen for a PCP appointment and then they come into the ED within 24 or 48 hours. And I think another custom report was with the readmissions and sepsis. But yeah, MVC has been great with helping us pushing to get our brain thinking the push reports, and then we get creative with some of the other data requests.
But yeah, thank you. That's exactly where I was going. I was kind of trying to follow the process a little. Also done some custom stuff with us. So when you got this report, was there anything that you found to be very surprising or contradictory, or sort of how did you all get to the next step then of making that custom analytics request?
I don't think I think it just, as I had mentioned, I found it interesting with the where we had the higher amounts of patients and then the readmissions, that it corresponded with COVID. And just then trying to, as we're looking at sepsis, and one of the things I hope by trying to do more upfront, that we will then be able to look at some of those comorbidities also. And do they have diabetes, or what respiratory are they here with? What is the cause of that sepsis, to then be able to hit the education right, and hopefully have maybe different services at home help prevent that readmission.
Yeah, thank you. That's great. We just love to hear when these things kind of, I don't want to say snowball because that's kind of often used in a negative light, but really get things rolling. So we do have a couple other questions that have popped up in the chat.
Real quick before we go to those questions, just to say too, on the custom reports, honestly, what really gets my brain going is sitting in on meetings like this, and I'll hear what other people are doing, and then that's what gets my brain thinking, to say, oh, well, we don't get a push report with this, but could it lead to? So that's where some of the push report ideas that came, or custom reports that came from, also was just sessions like this. So okay, next question.
That's exactly what we're going for. Thank you. Yeah, so Sherry was wondering, are your real-time audits electronic or manual?
It's mainly manual. We're still in that development phase, but the report, the person shows up on the report, that's electronic, and that just automatically flows through the report to her inbox, and then she'll manually kind of go through the chart to see, review, audit it. What do we need to be watching for, and are we hitting the measure? Does that answer?
I think, yeah, Sherry, I think that if you had more to that question, please feel free to unmute. But that also says, are you guys, Sherry, using a electronic or automated, or is anybody that's on the call have electronic or automated real-time audits that they are doing? I'm thinking like with AI bleeding its way into all of the things that we do, maybe there's something folks are aware of that they would want to speak about with us.
Hey, this is Sammy. Can you guys hear me?
Yeah.
We use equality check for abstraction. Is that what you guys use?
No, we're the company we're using is Qcentrics.
Qcentrics, okay.
Mhm.
So Sammy, you said you guys use equality.
Yeah, that's our abstraction tool that's built in Cerner.
Oh,
So we used to actually we used to use Qcentrics, but since we went to Cerner, we started using equality check instead of what was that you said you used, Irene?
the Qcentrics.
Qcentrics, yeah. So in equality checks, it's nice because you get it will trigger patients that have severe sepsis alerts or that are being treated for. So there's a couple triggers. So if patient has severe sepsis, also if a diagnosis for a patient goes in ED for sepsis, that will trigger the patient to populate into a real-time daily abstraction in equality. And there are a couple other things that will trigger that patient to populate into our daily report to abstract. So that's been really helpful for us to do real-time monitoring. I can probably see most of the patients. I would say about 80% of the patients that come through the ED in real time.
I'm gonna have to look at that then.
So that's one of the advantages of you doing the abstraction yourself. But if you have a separate source that's doing the abstraction, I wonder how that would look for you, or if you guys can actually get equality check even though you're not doing the abstraction.
Well, and that's actually one of our next steps, kind of learning right now and then seeing if we can move it back in-house. So it's a good hint to have to know
Yeah,
there's
it's
options.
I definitely would I don't know if I would like someone else to abstract our our cases, even though you get tied to them obviously, but
Mhm.
I think you have more advantages, especially in terms of education and fixing things real time, and with the abstracted cases, I think so at least. But yeah, so
Yeah.
there are many options out there depending on what systems you use, but Cerner has a good one with equality check.
Thank you. Yeah, our quality team went through quite a transition there, right about the start of COVID and through. So we needed that help with abstractions and things. But yeah, I appreciate knowing to look at that more. So thank you, Sammy.
Yeah. And I think what you guys touched on there kind of ties in a little bit to Amy's next question about if your site is going to go to in-house September 1 abstractions or continue with the vendor. Thank you.
We are looking at the idea. Not sure where I was going to land yet, but we're trying to train and improve our knowledge base and ability so that we can bring it back inside. Long-term
and
goal.
that sounds great. And then there's a couple other questions in between, but staying along sort of the same theme that we're talking about before switching gears a little bit for some of the other questions. When you say real time, do you mean you're getting the reports the same day the patient was treated? Was the question from Carol.
Yep, the report will fire every morning. So it's a 24-hour look back, and anybody that had been in that day prior and the sepsis or SIRS alert fired for that patient, that falls onto the report that our coordinator gets.
Okay. And again, staying in alignment with that, Amanda mentioned that Epic has a sepsis checklist track board that can be triggered based on documentation for US code sepsis. We have a patient list that is created, or sorry, for us, my chat's a little broken up here. Code sepsis. We have a patient list that is created and you can view components of the sepsis bundle. There are very few limitations we found, but it's great visual and way to monitor patients. Thank you for adding that, Amanda. That's great tip for everybody. And then Rebecca said we have an EC code sepsis program at our site. They page the EC code sepsis to the phone. What's going on? It's jumping all around on me. And the sepsis coordinator can follow the patient in real time and give feedback. So, those are the questions that are sort of related to the auditing process, but then it looks like there's also a couple questions here related to your sepsis team meeting and that process. So Mary was wondering, do you think the sepsis team meeting quarterly was sufficient to review the follow-ups?
We've actually, our sepsis team in the last 3 years that I've been in quality, it's varied for frequency. It was quarterly, and then we moved it to monthly to start really getting a handle on it and have some meaningful discussions. And then we moved to about every other month as we were to help with have new data to talk about and review. And then this year, we're just now starting to move it back again to quarterly, partly in relation to the length of time it's getting for our results to come in so that we have those cases to discuss. And then also trying to pair it up with our antimicrobial stewardship committee. Comparing those two groups is something I saw I don't remember which conference it was hosted by, but it was an initiative that was working very well and was sepsis for using antibiotics. So trying to help drive improvement in both of our sepsis program and the antimicrobial stewardship program by linking them and then helping to just bring that, real life example together with antibiotics and sepsis and treatments. And so we'll see. The first meeting is next week. And I don't know that an hour is actually going to, like this first meeting, an hour will be enough, but we might need to move it to an hour and a half. We'll have to see if it really does make sense and as we do it to keep it that way. And I also see maybe needing to have like an ad hoc sepsis subcommittee meeting in between the quarterly meetings as we get, if we have a whole bunch of follow-ups to review or something like that. So it's still all in development phase, but I am hopeful and I do think it will work.
You involve like clinical staff in those meetings and reviews, or how often? There's a question, kind of twofold here. There's a question in the chat about working on the manual monthly review with provider follow-up letters for closer to real-time follow-up, and what kind of provider follow-up are you utilizing? Just kind of trying to tie those two things in together.
Yeah, well, we're very fortunate to have our chief medical officer is involved. He's lead of our hospitalist group and inpatient, and he is very involved with both sepsis and antimicrobial stewardship. And then our ED director is also really involved with our sepsis group. So it's nice we can just sit down and have a conversation, or they respond great to email to be able to help us with, here's what we're seeing. Can you take another look at this chart for us? And then if there is that provider education needed, they are owning that step and taking it to the providers and speaking with them about the findings. And then if needed, of course, take away identifiers, but do larger group education with the whole team if that's needed.
And then we do have a question. I'm going to move slides here because I think this also speaks a little bit up to, or can lead us to speak a little bit too about your tool that you shared. And this will go out to everybody when we send the slides out. But Paula had asked if your site uses sepsis order sets, and if so, what the compliance rate is. So I was just kind of trying to bring us back to this.
Yes. So sepsis order sets, gosh, when we went live when we first instituted those, I remember it was several years ago, and compliance was a struggle. Honestly, I don't think we have ran a true report lately to say, here's what the sepsis order set compliance is. Because there's evidence in almost every chart as we're going through to review what the fallouts that was used. When that's not used, there's definitely a higher rate of fallout, but they do use the order sets, but it has been a while since we've ran that. I haven't ran it since I've been in quality for 3 years. So looking at that order set compliance would be a good validation that we are still using it. And it's a good question. Thank you.
With that question, is there anybody on the call that has had, I mean, we hear this so much, and not just with sepsis, but with a lot of things, right? That those order sets may not get the use that we intend for them to when we put them into place. So if there's anybody on the call that wants to speak up about a strategy that you have utilized to increase your compliance with using order sets, whether it be the sepsis or others, you know, go ahead and unmute yourself. This is our time to use each other's brains to help each other improve. And also too, looking at your tool here, this is really, really great. And I think it'd be very helpful for us to send out to folks. Anybody on the call have one that they would like to also share with us?
Hi, this is Julie from My Michigan. Can you hear me?
Yeah, Julie, hi.
Hi. So the second question you asked was, do we have a tool? We do have something similar to this that we use, but I kind of put one into a process flow more because that was something that the ED providers wanted, less wordy, just like kind of do this, then do this, then do this to follow along. So I have something similar to that. But we were talking about order sets prior to that, and it's very challenging to get providers to use order sets. For some reason, they just like to use order panels, or just click off orders one at a time and not use an order set. I think our order sets are used maybe 30 or 40% of the time. And we just had a committee meeting a couple of weeks ago, and I was talking to the providers on the call, and I'm like, asked all the questions. Is this not intuitive? Does this not work for you? Is there a better way we could give you the order sets? They've been the same for several years. Do you want them redone? And their answer was that yes, they want us to relook at them and just like streamline them and make them much easier. And there was a team that has just redone the pneumonia order sets here. So we're going to go to that team and find out what worked for them, because the providers are happier with that. So they just really wanted it slimmed down, just the basic stuff, not too many words. So that's what we're moving towards here, is just trying to make it a little bit better.
But yeah, I can see that. That's how that might be the case. They may be hesitant if it's a lot to read through, but they want to know exactly what they're ordering. They may be hesitant to select the order set, because then they have to go through so much to ensure that they're comfortable with what they're putting in there. So thanks, Julie. That's great advice. And Jennifer also added to that they track at her site, they track each provider order set use % and share that at the sepsis committee. Helps to hold everyone accountable. And admittedly, the Epic sepsis order set is kind of clunky. So thank you, Jennifer. If after we get done with this meeting, if there are folks who have something like this that they want to share with us, please feel free to send it. We'll find a way to incorporate and include things so that your peers can look at that if you're interested. So we have a few more minutes left here. Is there anybody who wants to kind of come in with a last minute question? Well, I'll read off Carol's comment while you guys are thinking about that she runs a report in Epic to see who is using the order set and who isn't. The ED director is highly engaged in sepsis, and the docs there know if they aren't using the order set, they will be called out. We expect it to be used in our ED, and their rate is 75% for the hospital. So that's really good. Carol, thank you. And we're working on better inpatient compliance. They have a research study within the region that has shown the benefits of order use. Another thing we'd be happy to have you share with us is more on that research study that we can share with members too. So thank you, Carol. Okay.
You're welcome.
All right, I'll give you guys another minute here. If you have questions, you want to unmute and ask Irene or each other. You're welcome to ask each other questions too.
I can share something really quick.
Sure.
Sammy, we had that we have a really good ED that uses the ED fever sepsis power plans, but our hospital inpatient side doesn't really use them that much, because they think that they can piece it together. And one of the kind of things we talked to them about is, the power plans bridges communications with the RNs. And I think that kind of hit home for them too. Instead of piecing it together, some of the RNs, if a physician is piecing the initial, if they put in the initial lactic, the blood culture, the antibiotic by themselves without, talking to the nurse, some nurses don't know that, the patient's being treated for sepsis. So putting in the order sets, like a DKA order set, kind of bridges that communication with the RNs, so they know, these have to be done within 3 hours.
That's a really good point that you raise, is, the help that has with the communication with the RNs, because as we all know, we're in healthcare, we're always trying to do more with less, and what ends up falling at the wayside sometimes is that communication piece. So thank you for bringing that up and pointing that out.
Hi, this is Christina from McLaren, Oakland. We also have a form similar to what's shown on the screen that we use. It's more of a flow worksheet form that has really helped us. The provider will put at the top area the time of sepsis recognition, and then they kind of hand it off to the nurse, and it'll have the steps for the 3-hour and the 6-hour bundles. We've seen tremendous increase in compliance. Just it helps to keep the nurses on track and aware of those the time of presentation window, so that they know they have to get that antibiotic hung. They know they got to draw the blood culture before. It's a really nice sheet that we created. We're still tweaking it at Oakland. We've been working, I think I've been on the sepsis program for about 2 years now, and we've been working really hard to increase our compliance numbers, and we've been doing very well. We're not quite where we want to be, but we have developed a multidisciplinary sepsis team. We meet every month, and then we're currently in the process of doing an A3 to kind of break down what those challenges are and what we can do to fix those. So we have a couple of different areas that we're focusing on. Our inpatient side, the ED, we've been honing in probably the past 2 years because most of the time we know when they come in through the ED, that's when they are diagnosed, and they're doing phenomenal. Now we're starting to roll over to the inpatient side. Our ED side is amazing at using like the dot phrases. They're wonderful about using the order sets. Our inpatient side, we've identified several knowledge deficits to where they didn't even know that an order set existed. They did not know about the dot phrase. So we're doing a lot of education now on the inpatient side, as well as continuing to push in the ED side to keep them doing better. But a worksheet like this, really, it highly affected us. Our numbers went much, much higher for compliance once we developed the worksheet.
That's really great. And I think something, all of you are sharing such great ideas. I'd like for you to think about, as you move forward, especially Christina, as you're moving forward with that A3. And once you kind of get that rolled out and see what some of the results are, we've got more work groups to come towards the end of the year and even into next year. So would love if any of you think about presenting some of what you're doing in the future. That would be really good. And then I'll also read Paula's comment here to add an order set to notify the quality sepsis coordinator to the sepsis order set might be helpful to track sepsis patients in real time. And compliance with using the order sets would be key. And then it looks like Carly was asking Christina if you can share that worksheet. I know you said you had some work to do on it yet, it sounded like, but when you're ready and available, I think that's another a good share out.
Yeah, we can share what we have. Like I said, it's still, the sheet that I have now has been in use for a little over a year or so, and we just made some minor changes to it maybe a month or so ago based on some recommendations we saw through our committee. I can share that on now, or I can just email it to you, Jessica, whatever works.
Yeah, if you want to send that over to me, I'll make sure that we get that out. We typically, as you know, send out our follow-up email to the work group about the day or so, within the day or so afterwards. So whenever you get a chance to shoot that over, I'll try to include it there. Otherwise, we can send out a separate email next week. I know that might be a fast turnaround. So
Okay.
thank you. All right. Well, this has been a great conversation. You guys have all added lots to our wealth of knowledge here, and I appreciate that. Follow-up questions can come through us if you think of things as you are kind of feeding some of this information back to your team. Whoops, sorry. I went too far on my slides here, but I do need to make sure that I mention that we have more sepsis work groups coming up in July and October, and you can register for those and add those to your calendars. And then we have our upcoming preoperative testing work group coming up May. We will have Whitney Soul from Munson Healthcare Cadillac Hospital joining us, and a cardiac rehab work group also in May. And of course, we have our May collaborative wide meeting that is just before both of those work groups on May 10th. If you haven't already registered to join us there, please do so. We will be in Midland for that. And then would like to thank you. Our email address, as always, is there for you to reach out to us. And Jennifer, I saw your question about the networking events. I appreciate everybody's patience as we are really working on trying to get those networking events planned, and we will be sending something out very soon about them. You can expect to see something for this summer. There'll be multiple opportunities. So thank you for your patience on that. Shannon just put the Qualtrics survey in the chat for you to get your credit for your attendance, and to please give us your feedback so that we can continue to make the adjustments and make these better and better every time. And then, sorry, I thought I saw another question pop up there before I wrapped up. So I think that's it. So thank you all for joining us.